First, my congratulations to the iOS and all the associated organizations for putting this together. As you said, it's so topical today. All of us really need to get together to do this. So, personal thanks to Dr. Sharma, Dr. Kim, and of course, Professor Namrata and Professor Mahipal for making this happen. We can interact and perhaps find a way forward. So, what I am going to do today is present to you a little bit about COVID and mucormycosis to introduce the topic to you all. And then, of course, we can move forward to on the panel and uh, and clear some issues. So, this is not quite me alone. This is the COVID mucor disease management group that has been put together at our institution. And that, of course, includes endocrinologists, of course, people who treat COVID per se itself, infectious diseases, medicine, and anesthesiologists, ophthalmologists. So all of us together coming through microbiologists to put our thoughts together. It's a collective consensus. It's not quite comprehensive as to what I'm going to be speaking to you for the simple reason that there is going to be another panel out there. And it's evidence based from the point of view that it looks at the best available evidence and our own experience and judgment. So not the narrow sense of evidence based, but evidence based as it should be the triad of uh, of the best available evidence and clinical judgment. So let me take you through to what was the situation before we had COVID. This is our department of publication, which should soon be in print, which looked at iron metabolism on invasive fungal sinusitis. But the point out here is that it's pre-COVID, 2017 to 2019. In a 2-year period, we had seen 25 patients. And yes, most of them had diabetes, uncontrolled diabetes. So that was by far the commonest underlying condition which was predisposing to mucormycosis then. Of course, we have patients who have kidney issues, end-stage renal failure on dialysis. We have patients post-transplantation. We have patients post-leukemia chemotherapy. In the West, these other situations are more common with regard to the underlying bed on which mucormycosis develops, but in our situation, it has generally been diabetes. So what happened to these patients then pre-COVID? 60% had progression. So, I mean, they present to you and you get the treatment in, but they had a little bit of progression before you can actually control. But not everybody obviously could be controlled, and there was a fair amount of mortality. This is much less than what used to be, but nevertheless fairly high. And we also noticed in this paper, that's the point of this paper, that serum ferritin was associated with progression or worsening. Now, serum ferritin over the last year or two with COVID has become such a popular, common investigation. It's on everybody's fingertips, but at that time, it was new information. So this is where we stood. So what about COVID? So COVID, this is again one of our earliest publications at the time when we were actually admitting as inpatients everybody who had COVID, more from the point of view of isolation than from the point of view of treatment, the very early days. And then we put forward this prospective cohort. And the only reason I put this forward is to say that a lot of them, of course, had ENT manifestations, the point of this paper. And that comorbidities in terms of diabetes was fairly common. I'm told that the population prevalence in our situation in India is about 9%. And in this cohort, we had 6% then. Anyway, just to say that a fair number have diabetes even otherwise. What about COVID and mucor? So this is again the experience from our institution in the first 10 months of the COVID epidemic. And we had then treated as inpatients 6,250 patients, and only 2 of them went on to develop rhino-orbitocerebral mucormycosis. These were both immunocompromised patients, and in this case, they were both having kidney disease, which was the cause of their immunocompromise. What is to be noted is that these patients got cured of their COVID, got discharged, and then subsequently developed this illness. So even otherwise, these situations predispose to mucormycosis, the post-renal transplant and stage renal disease situations. But it does seem it's a little bit higher than otherwise when associated with COVID. We had 14 other patients who presented with mucor and concurrent COVID. So they really presented with mucor, not with COVID. Many were asymptomatic, you would notice. Some had mild illness. Only a few had symptomatic, significant COVID-19 infection. Most of them were rhinocerebral, rhino-orbitocerebral, and most had comorbidities, which was almost always diabetes. So as I said, the pattern is the same as used to happen in our situation even before that, but except that the incidence has certainly seems to have gone up. And world over, we've been having it was recognized that COVID was leading to a higher incidence of mucormycosis. Why this was happening, not quite clear, but it does seem that COVID itself causes some immunocompromise. Lymphopenia is a frequent accompaniment of COVID infection, and I'm sure Dr. Naval will take this further as we go on. So if we put this together, our own incidence in terms of the patients we treated and patients having delayed was 1 in 3,000 in patients who were already immunocompromised. But overall, the incidence seemed to be 1 in 400. And this is, of course, an impression on a small cohort. But a similar impression of 0.27% has come out from a study put together by Gujarat, by a consortium, I would say, which has looked at a multicentric evaluation, which again is in print, and this is personal communication with Dr. Atul Patel from Ahmedabad, and similar 0.27% incidence. What happened to these patients? So we had 15 who had rhino-orbitocerebral, 1 with pulmonary. The patient with pulmonary died. Unfortunately, mortality is much higher in the pulmonary situation. But even with the rhino-orbitocerebral situation, we had some who were rhinologic, some who were orbital, and a fair number who were rhino-orbitocerebral, and the mortality was about 33%. So let me tell you a little bit about mucormycosis. So mucormycosis, or the mucormycetoma, is a group of fungi. There are many species as part of it: Rhizopus, mucor, many others. And it is ubiquitous. It's everywhere. It's always been everywhere. It's in soil. It's in decaying organic matter. If you have leaves which are decaying, maybe even fruits which are decaying, you will have this fungus in there. The spores are there in the air. They have always been. Is there a seasonal variation? It's been reported from the US. It's been reported from Israel. We haven't quite seen one. But having said that, I'm not so sure. Nobody has looked very closely at it. We haven't seen one. And obviously in the West or in the US or in colder climates, it's fairly obvious that there are parts of the year when you have no leaves and hardly any vegetation or decaying organic matter, and you have decreased incidence in the winter months. But the CDC says, and quite rightly, that most people come in contact with the microscopic fungal spores every day. So we all do. It's always there. But it doesn't cause an infection because it's ultimately an opportunistic infection. It's an opportunistic infection, which really strikes you only if you're immunocompromised. I told you the setting in which it strikes us in our situation. I told you the setting in which it strikes generally the West. We continue to have a fair amount of diabetic ketoacidosis, and that is the commonest setting in which it happens to us. I'll now sort of also put together our thoughts as to why it's happening now. I told you what was happening. We had a 1 in 400 incidence previously before this current surge. And in this current surge, our impression is that it is, of course, related to COVID-19 related immunosuppression. It is related to poor glycemic control. And it is also related to the immunocompromising treatment that is now so very prevalent in this current wave. This was not there in the previous wave. For the previous wave, we were treating these patients with chloroquine rather than with steroids. But now treatment has gravitated down to steroids. And it is really this group, or the high-risk group. And I must say that we're not quite sure that in this high-risk group with poor glycemic control and treatment with steroids and immunomodulators, what the exact incidence is. The overall incidence seems to be 1 in 400. But in this new scenario, the exact incidence for this high-risk groups remains unknown. We haven't quite worked out as to whether we should be giving prophylactic treatment to this group, but the general consensus seems to be till date that it's not justified. But as I said, it's an open question. So I'm now taking you back to some older slides just to say that how things used to be and the principles as to how these are to be treated have been put forth quite a while ago. It's also lazy on my part to just pull out some previous slides and put them up for you to look at, but it's so to say that these are established principles. So high mortality, and this is documented by us in 2003. Now our mortality is half of this, as you just saw. Also documented by others at that moment in time. So in the 2002, this publication, which I quite liked, and actually done a review of all the reported cases till then and had a mortality of 48%. Their own mortality was a bit higher. And greatest mortality in first week, that you have to realize. Prognosis depends primarily on the stage of the disease. If it's gone from rhino to rhino-orbital to rhino-orbitocerebral, especially rhino-orbitocerebral, that's when mortality really starts to happen. Untreated, of course, is likely to have a very high mortality. It depends largely on the underlying illness and the immunocompromise. If the immunocompromise persists, then it's very difficult to control these patients. If the immunocompromise or the underlying illness can be controlled by controlling of diabetes or controlling of decreased TLC counts, and of course things can get better. We found, and there's other literature to say that early onset of medical treatment was quite important, and of course completeness of surgical debridement. This was a recommendation with regard to how surgery need to be done then, and it continues to be the same, which basically says that you should do it when safe. You should debride till the bleeding periphery. But what really changed in our practice over the last 20 years was that while previously it used to be surgical, now it's medical plus surgical. So you have to be focused both on treatment of the underlying disease or the immunocompromise and focused on the early onset of getting the antifungals in and of course getting a surgery in. So early diagnosis also meant that oftentimes that you had to do presumptive therapy. So that means that sometimes there's a cycle to this that unless you've demonstrated the fungus, you don't want to give antifungal treatment, but we do give antibacterial treatment unless we have actually before we have grown the bacteria. So here also we have moved on to doing presumptive treatment for strong clinical suspicion situations in the high risk group. And to my mind, that has helped mortality. But let me take you through now to the clinical pointers. So you have to realize that unlike bacterial disease, this spreads along the vessels, and so spread is often non-contiguous. You won't quite see a lot of PNS disease within erodes through the lamina papyracea, enters the orbit. Oftentimes you would see two separate lesions. And oftentimes lesions are actually more gangrenous because this is an angioinvasive disease which comes through the vessels, causes gangrene. That's the reason it's suddenly being called black fungus. Of course, there's nothing black about it. Every medical professional knows. But yes, the gangrene is dark and black. So what we discovered and what has been corroborated by other publications is that perinasal cellulitis and perialar anesthesia, or rather facial anesthesia, are early signs, and you should watch out for them. Periorbital cellulitis, of course, is an early sign. Palatal gangrene and ulceration are early signs. Basically, if you see gangrene anywhere along the anatomy of the PNS, you should be starting to get worried, especially in the high-risk setting. The other thing that we pointed out, and others have also pointed out, that the traditional books have always said to you that the fungus disease will give you mottled bone erosion and profuse. That is hardly the situation. These patients do not have suppurative sinusitis. These patients have gangrenous involvement of the mucosa. You do not see very dramatic things on the CT. Bone erosion is almost never seen in the early disease. Of course, if you wait for later disease, you will see it all, but it would be inappropriate to wait for those signs if you made the sign. So generally, you will say minimal radiological findings. And in fact, if you see a patient with sinusitis with minimal radiological findings, we tend to get more worried. If somebody has obvious clinical sinusitis and minimal signs and minimal opacification, we get worried. And this is the typical patient which I had put forth in 2003 and continues to be the same. You'll get a little bit of palatal darkening, early sign, and of course, some facial cellulitis. When you do radiology, then you will not see very much there. And that's exactly the point I'm trying to make. You will not see very much there. You will probably not see too much bone erosion. You will not even see too much disease, localized disease. And the principle of treatment has been diabetes control. Of course, any immunocompromised control, usually diabetes in our setting, early presumptive ampho B, and debridement. So debridement from being what we used to do on the day one or the first 12 hours has slowly moved out to be a little bit later, but we focus on the other things now. I'm not saying we delay debridement, but just that you don't focus only on the debridement. I'm just putting forth these two papers because they have influenced our practice. One I've already mentioned, Dr. Talmi's paper, and the other is our own analysis. And the points to be made are that the overall survival is poor, but now is getting better. As I said, our previous situation was 1/3 mortality. All patients had at least one recognized underlying disorder. That is most important. It would be very unusual to have a situation without an underlying disorder. In this situation, it's usually COVID plus something. And often in the early stages of disease, clinical signs are not apparent. In this prospective study, the clinical signs we found were perinasal cellulitis and paresthesia. And this is important because this is prospective. Retrospective is very difficult to look at early clinical signs. Other information that came through, was that maximum mortality is in week 1. You can minimize mortality by controlling the underlying immunocompromise and just repeating the salient points I've already said. Early initiation of antifungal treatment and radical debridement. They're acute and chronic forms. Of course, we're almost always seeing the acute form, but if you see someone who's chronic, then that probably means that this is not very immunocompromised situation, and you generally expect a good prognosis in the chronic form. Most times we don't quite see the chronic form, but if you see some chronic form, as we were seeing in the previous wave, that is generally a little bit comforting. This was our data from 20 years ago, which also showed that the only patients who really cured at that time were patients where when we got the amphotericin B in early, or patients who had chronic kind of disease. Since then, things have improved because understanding has improved. Since then, things have improved because the pharmacology has improved. There's GMCF available. There's, of course, liposomal amphotericin B available, so you can push in greater volumes quickly. Also, I made the point that classical described radiology of bone erosion is not seen, and it is a lack of florid radiological sign which should arouse suspicion. This is about the early clinical signs, which I've always come through you about, and also to say that prognosis depends on the stage of presentation. So it's very important to have early clinical signs and recognize them at the early stage, because when you get them at the early stage, naturally you can get good cure rates. So 100% at rhino, 80% at rhino orbital. We really don't believe rhino orbital impacts prognosis as long as you can get in very quickly with regard to your treatment. Rhino orbital cerebral starts to impact prognosis very dramatically. So now I'll take you through, I mean, we've already been through the general basics of what this illness is about and how we have gone about organizing our response to this. Of course, this would be taken up further with the panel and the subsequent talks. So one, of course, was awareness, and we did notice this was arising. We did notice that when the pandemic came to Maharashtra and to Gujarat a couple of months ago, when the second wave came, then they started to face an increase in this situation. So we flagged it both at every level, and certainly at our institution, we have been able to shore up Ampho B, and so far we have been doing reasonably well with regard to our stocks, but we now do need more. That is the problem. We have created awareness at the central level, and there also stocks are being shored up. So certainly, as Dr. Mahipal said, when there's a 20-30 fold increase in the number, maybe 100-fold increase in the number of cases, you can never quite expect things to be perfectly normal. But part of the problem has been looked at, and still we are having medicines around, though running short. We had a departmental consensus meeting just to get through on how to treat this when it comes to us expecting it. We appointed a nodal coordinator. Of course, we all know how to treat, but it's still nice to get together, just like in this current seminar. There's a multidisciplinary clinical care team at the institution. Dr. Naval Kishore is going to tell you about it as we go on. Dr. Neelam is part of it. All of us are part of it, really. And we set up communications. So we have a WhatsApp group. We have an online dashboard. We sort of tend to go by it and look. This is an online dashboard I tend to look at every now and then. And though we haven't quite analyzed all the data yet, it's still coming in. It's still early days. But just to get some trends in, we still have patients who first get COVID and then get mucor, but or wherein sort of who present to us with mucor, and we find out that they also have had COVID. We have those patients. We come to mucor and we find out they have COVID. But the large majority are patients who have already had mucor, have already had COVID, have been diagnosed with COVID, and then are presenting with mucor. And this is generally occurring at about week 3, but of course it's very variable, but generally occurring at week 3. So as I said, the last time we had a lot of patients who presented with mucor and were discovered to have COVID. We still have that odd, but generally we are now having patients who have been diagnosed as COVID and then developing mucor lately. Many of them have been treated at home isolation. I would say the majority have been treated at home isolation. It's not that they need to be in hospital. Many of them have mild to moderate disease. This is just a snapshot from that, from our data. And most patients haven't had oxygen. So to say that oxygen causes it, nobody's saying that there should be unsanitary or unhygienic conditions with oxygen. As we have already said, the mucus spores have always been everywhere, but that is not the only story, and perhaps not the story at all. But we will find out more as we move on. And almost everybody has had steroids. Almost, not everybody. There are some no's, as you can see out there, but steroid treatment is widely prevalent in these patients. So the triad I mentioned when we were starting out, that the triad of the high-risk group, patients who have had mucor, patients who have had patients who are diabetics, and patients who are on steroid, is really the difference between now and before. I think previously it was mucor, previously it was COVID plus diabetics, now it's COVID plus diabetics plus steroid. What I also want to mention is that unlike the usual expectation that at the day 10 they would have become RT-PCR negative, or day 12 or day 15, we generally find that these patients are almost always persisting with RT-PCR positive, and maybe that too is a manifestation of immunocompromise that these patients are facing. This particular snapshot doesn't quite show, but diabetes also very prevalent. So this was really when I checked it up in the early days when we didn't have the full thing in, but because this is a work in progress, we don't have data for everyone, but even for the 50 that we had, 30 had documented diabetes. Yesterday when I took rounds, everybody. That's all I can say. I didn't see every patient. I look at the NCI thing, everybody had diabetes. It was getting under control, everybody had diabetes. So that is the setting. And what have we done after that? Of course, the patient communications of patient precautions, communication of mucor checklist or early onset signs to COVID care teams in our own institution and outside, and clinical care guidelines, which have been set up by a multidisciplinary group. So these are guidance for patients, which basically telling them that this is something that has always been around. It's not a new disease. We have the experience with treating it, and it's rare, but of course, a serious complication of COVID-19. What is causing the mucus surge? I've already told you. We are communicating that to patients so that they're aware about the high-risk group. And what are the alarming symptoms to watch out for? We have discussed in this forum. This forum knows we are medics. What to do, not to do, basically telling them, of course, priority to your COVID when you get it, but to be careful with steroids and generally ensure reasonable hygiene. Get your sugar level checked. And if the sugar level is high, of course, get it treated. We do know that COVID can sometimes precipitate diabetes, so it's important for the population to know that too. This is our communication to physicians, which again looks at similarly. We say that there's a multi-specialty clinical teams in place. And the first thing to do is to categorize patients as COVID positive and COVID negative. As I said to you, COVID infections are persistent in this group of patients. And even today, in the vast majority of patients we have, I would say 90% of patients we have turning out to be COVID positive, even though they are beyond the 10-day limit. So these patients seem to have some immunocompromise, which is pushing them. And this is being sensitized to our physicians and physicians' welfare. Why the surge in mucormycosis? I told you already. Checklist of sentinel signs and symptoms, very similar to what we tell the patients, but a little bit more detailed, going beyond the early signs to subsequent signs. And then the listing of the treatment principles and listing of an even more detailed list of treatment principles, which they can access by clicking on the link below. So this is in circulation, and of course, we would be happy if the IIS wants to use these and guide themselves. So I come to end of what I have to say today. This is where we stand today. We have the principles in place of how to minimize mortality when we are faced with the problem. which is medical plus surgical treatment. We have in place as to how to do early diagnosis. We have in place the principles of how to treat these patients. And thank you. We don't hear you.
I can't unmute.